The challenge is, what's the evidence out there? And the reason why we're all here at this tea party is how do we close the gap between what we know and what we do? And that gap is getting bigger and bigger and bigger in every healthcare system, wherever you happen to be coming from globally. Most of us clinicians are trained to be excellent in that very small focus in this pathway. None of us were trained to look at a system accountability. And the uniqueness of this approach is to look at the whole pathway, is to educate the whole team responsible for this pathway.
We are data rich, but we're information poor.
Right.
And so one of the issues is to convert what's in a variety of data banks, if you like, and turn it into something which is accessible and understandable, but also irresistible to clinicians.
That's been very much part of some of the reforms of getting good staging data, get good outcome data on colorectal cancer, so that this other recurring thing that we can trust the data that we're working with.
Where we have found it most useful, the perspective, additional perspective offered by the cost perspective. So we've always had a look at quality of care, but then the cost waterfall tool was extremely useful for us.
As we've gone through the project, we've started to find some very scary patient experience and patient information from the safety and quality side of things that we're trying to validate at the moment to really understand is as bad as we thought, because we knew what the problem areas were we went in, but I think we're finding the scale is bigger than maybe what we had anticipated. I love going through this sort of a process where at the start we could script who was going to say what around the room as we went around our clinical advisory group in terms of what the problem was and what the issue that needed to be solved.
You have to face the initial, "Ooh, this is not for me," and then you appeal to principle, and the principle is that this is your patients, that we're looking after, and you should think about it. And so if you do this, you will engage enough of the crowd, of the discipline, to carry the rest.
The tool has certainly helped us to energize clinicians. We were certainly quite surprised and happily surprised by the very positive response we got from our clinicians.
The tools that McKinsey use give us that granularity in terms of the issues, but we also have to then match that with going out and doing as many visits and other activities we can do to engage clinicians in the workforce to make this part of the change process. It's not the change process on its own.
We just started a national bowel screening program last year, and so with that, there is increasing interest in looking at how we are currently performing along the pathway.
When we started to look at the McKinsey pathway, and there were a whole lot of questions like about whether the screening was documented in the medical record and whether the issue of prevention had been documented in the medical record, and I had to say that we were not doing that because it was all happening outside.
We discovered that our screening program was set up to be completely anonymised from primary care. So a GP can see a patient and have no idea whether that patient has or hasn't accepted a screening episode.
This is sort of an ideal opportunity to look in detail at our pathways, and we're probably the networks can have a much bigger role than we've ever had before now in advising our commissioners in how we go about commissioning care.
We've been interested in pathway dynamics for a long time, recognising it's only through a pathway understanding that you can really get the metrics and relate them together. And so we're delighted to be within this McKinsey program to help refine some of our ideas about colorectal cancer.
If you look at the background analytical work that your team has done, there are wonderful opportunities there which are well beyond the presentation today, and that's the discussion we need to have, and then try to define what are the priority list. We're not going to deal with the whole pathway, but the ones that have the biggest impact, whether these are quality impacts, whether these are economic impact for the future.